Hello and welcome. We'll wait just a few more seconds as people are entering the session. As we wait, I would like to remind everyone that November is Epilepsy Awareness Month. And this year, our campaign is focused on encouraging people impacted by epilepsy to speak about their experiences through the Silence the Stigma campaign. If you haven't already, visit efmn.org to find more information. Thank you everyone for joining us for the Innovations in Epilepsy and Wellness Expo. I am Heather Bessinen, Associate Executive Director of Mission and Strategy at the Epilepsy Foundation of Minnesota. Today, we welcome Dr. Joanne Rogan to speak about living with seizures for those who are newly diagnosed with epilepsy. Before we start the session, I would like to go over some housekeeping information. For this webinar, your camera and microphones are hidden as the focus will be on the speakers and presentations. Following Dr. Rogan's presentation, we will have a panel discussion with Anna Shukla, Dr. Rogan, and Dr. Zaccarello to talk more about today's topic. We will close with a Q&A session where you are able to ask questions to our experts. You will see a Q&A icon on your Zoom toolbar. For many of you, that will be at the bottom of your screen, and you can ask questions there. Now, I would like to introduce Anna Shukla, our moderator for the session. Anna is a family nurse practitioner. She has been working at the Minneapolis VA in the neurology department for the past 2.5 years. She is also a member of the Epilepsy Foundation of Minnesota's Professional Advisory Board. At the Minneapolis VA, Anna sees all types of neurological patients, and half of her clinic focuses on epilepsy patients. Anna also works closely with their Epilepsy Center of Excellence in helping advance offerings to patients with epilepsy, as well as helping run the Epilepsy Monitoring Unit. Her first experience with epilepsy was in the pediatric population. Anna spent 3 years as a school nurse at Bridgeview School in St. Paul while earning her nurse practitioner degree. This school provides education for students with severe, profound learning delays, and many of her students had epilepsy. She continues to learn about epilepsy and strives to provide the best quality of care to our veterans at the Minneapolis VA.
Hi, everyone.
Hi, Anna.
I'm Anna Shukla, and I have the distinct pleasure of introducing our speaker, Dr. Rogan. Dr. Joanne Rogan is Medical Director of the Midwest Center for Seizure Disorders at the Minneapolis Clinic of Neurology, and she is a clinical professor in neurology at the University of Minnesota. Dr. Rogan has served as an examiner for the American Board of Clinical Neurophysiology, the American Board of Registration for EEG Technologists, as well as the American Board of Psychiatry and Neurology. She served as chair of the Professional Advisory Board of the Epilepsy Foundation of Minnesota for over 20 years. Dr. Rogan has served as principal investigator and has participated in multiple clinical trials and research studies involving the new anti-epileptic drugs, as well as publishing in this area. Her site was the recipient of the INC Clinical Research Site Award, and Dr. Rogan is past president of the Minnesota Society of Neurological Sciences. So thank you so much for being here, and we are excited for your presentation.
There we go. Thank you, Anna and Heather, and to all of you for joining us for our Epilepsy Expo and asking me to talk about our newly diagnosed epilepsy and living well with seizures or without seizures. Next, this really is an exciting time for all of us with involved in epilepsy and neurology. When I started in practice and was in training, we had just a few drugs. Now, after a number of years, we've got over 20 new drugs. We have new formulations of our older drugs and new procedures. And yet, almost daily, I'm seeing people still having seizures. And the good news is, as I tell my patients, each one of these drugs truly makes a difference for our people with epilepsy. And for that reason, I say my goal is no seizures and no side effects. But the really good news is I see even more people who are not having seizures. So I saw in the last week or two patients who had had no seizures for a year and 4 years, and no seizures for 14 years and over 20 years. And you will be there as well. Next slide. So today we are going to talk about epilepsy and seizures. We're going to talk about how we know that you do have epilepsy, and then treatments, and how not to have seizures with epilepsy. Next slide. So I like to always start with the basics, so we're all on the same page, and talking about seizures. Next slide. So a seizure is a brief, uncontrolled electrical discharge in the brain that can result in a change in level of consciousness or alertness or motor activity. And next slide. If seizures tend to recur, then we call it epilepsy, or the tendency to have recurrent seizures. And that is the same thing as a seizure disorder. So epilepsy, seizure disorder, one and the same. Next slide. So how common is epilepsy? It's extremely common. It occurs in about 1.2% of the population per the CDC. There are about 3.4 million Americans with epilepsy, about 500,000 children, and about 150,000 people are diagnosed with epilepsy each year in the United States. One person in 26 will develop epilepsy at some point during their life. Interestingly, 6 to 9% of the population will have a single seizure that does not recur, and that is not epilepsy, and we would not treat. So we're going to talk about how we make that decision. Next slide. So what causes epilepsy? Anything that can irritate the brain. So infections, meningitis, encephalitis, birth injuries. There are some changes, developmental changes in the brain. Brain tumors, which we rule out with our MRI. Head injury, we have a name for that. We call it post-traumatic epilepsy. Strokes. Uncommonly, there can be a problem in the blood, and there's a small amount of people with epilepsy who have an inherited tendency, more common in our childhood epilepsies. But the number one cause is unknown. So in over half the time, we never find a reason why. Next slide. So when we talk about seizures, we're neurologists, we love to classify, and so we classify our seizures. Next slide. And seizures have been around forever. Hippocrates had epilepsy. Chief Justice John Roberts has epilepsy. Our wonderful moderator, our MC at our gala, Ashley Zilka, who talked about her seizures and now seizure-free as well. So it's common, but our naming has changed. So we divide our seizures into two types depending on where they begin. The focal seizures begin in one part of the brain, or partial seizures. The generalized seizures affect the whole brain at once. We also have unclassified, we don't have enough information yet, and status epilepticus, and those are the seizures that continue and which we use are rescue medications for, or two seizures that occur without regaining consciousness in between. Next slide. So our new classification, we call our seizures focal and generalized, and then we divide our focal seizures, previously partial seizures, depending on whether people have decreased awareness or not. Next slide. So our focal aware seizures are the ones we used to call simple partial seizures. And those can be simply a motor movement, a sensation, a feeling, a deja vu, but people are alert. This is my patient who came to me and said, Dr. Rogan, I can't play the oboe anymore because my hand keeps twitching randomly on its own. And he had a lesion on the other side of his brain and did very well. That's my patient I saw a week or two ago who has simply a tightening or sensation in her hand, sometimes twitches. These can progress to a focal unaware or generalized tonic-clonic seizure, and each of these have specific findings on our EEG, which we'll talk about. Next slide. Our focal unaware seizures are the ones we used to call complex partial seizures or partial onset seizures. And these are characterized by decreased awareness or confusion. They're usually brief, and people may just stop, stare. There may be fumbling movements with their clothes. They might walk around and touch things. And those are what we call automatisms. And people typically don't remember these. So don't worry if you don't remember you had the seizure. These and the focal aware can progress to generalized tonic-clonic. So this is my patient who was sitting in the front seat as a front row while I was giving a talk, and all of a sudden he looked up and stared and started moving his papers in front of him, lasted 2 to 3 minutes. And that was it. And then right back. Next slide. We also have our generalized seizures that affect the whole brain all at once. And those include our absence, tonic-clonic, myoclonic, which is just a brief twitch, generalized tonic-clonic, and atonic seizures in which people drop to the ground. Next slide. Our generalized tonic-clonic seizures are the seizures that people think about when they hear seizures or epilepsy or seizure disorder. Actually, our partial onset seizures are much more common. These previously were called grand mal seizures. So these start with losing consciousness. A person may give a grunt or groan or make a noise or yell out as the air rushes out of the lungs. And then there is tonic extension, so rigid extension of the arms and legs, and then clonic movements, which means rhythmic jerking. Usually it lasts 2 to 3 minutes and stops. And that's the duration of the seizure if your doctor asks. Afterwards, people will have a post-ictal state, which means they're tired or fatigued after the seizure. That can last for half an hour. It can be several hours. This is my patient I spoke to this weekend who still was feeling a little bit off a day or two after a generalized tonic-clonic seizure. Next slide. The absent seizures, spelled absence, are the seizures that we previously called petit mal seizures. These usually occur in children ages 5 to 15 or teens. They are a brief, again, suddenly lapse of awareness. So the person may just stop, stare, the eyes may blink. There might be little mouthing movements or a little bit of hand movement, very brief, and stop. And this type of seizure frequently has a family history, and some people outgrow this type of seizure. And again, typical EEG pattern, 3 per second spike wave. Next slide. Okay, so how do we know that you have epilepsy or a seizure disorder? We do our neurologic evaluation. Next slide. So first and most important, we take a history. What we want to know, what seizures, what happened. I'd rather have that than the name. We'll decide that after together. The seizures, I want to know how they begin, how long they last, what happens during. Do you have a warning or aura, which is often a focal aware seizure, or sometimes a prodrome, sort of a feeling before, or several little brief seizures. I want to know how frequent they are, if there are things that bring them on, and medications or treatments you've had before, and what happened. Did they work or not? Next slide. Then we do the neurologic examination. We examine the nerves around your head, your strength, your reflexes, sensation, and your coordination and walking. Is there anyone out there who has not had to take their finger and touch their nose? So we do that to look for a focal abnormality, suggesting there might be a focal lesion. And when you come back and we do this, we're looking to see, again, is there something focal or abnormal, and signs of medication toxicity or side effects. Next slide. Then we do tests, EEG, MRI, or CT. Next slide. So this is the MRI scan, pretty simple. You lie on a table, there's a loud clanging noise. Or CT you may have had in the ER, whatever, to rule out a structural abnormality. So this, if you've had an MRI, there have been no signs, or we rule out brain tumors or significant scarring or bleeding. So that's our MRI. Next slide. The EEG is really the mainstay of our treatment. It's our sort of gold standard. So the EEG, or the brainwave test with little wires on the outside of the head, comes in several flavors. The routine EEG is where you walk in and to our office or in the hospital and have the EEG, which maybe takes an hour. Now, 60% of people with epilepsy will have some abnormality on their EEG, but 40% it will be normal. So then we may do a sleep-deprived EEG where we keep you up all night, and then do the EEG because sleep deprivation is a very common cause of seizures, but also increases the chance of seeing abnormalities on the EEG. And the time it's most common is that time between wakefulness and sleep and in sleep. And that picks up about 80%. If it's still not clear, we may do a longer ambulatory EEG in your own home with or without video. And that if you have a seizure, we will see changes most often. Or if they're funny spells, it may tell us that they aren't really seizures and we don't have to use medications. And it shows us, most importantly, the signature signs on the EEG telling us interictally between seizures that you have a tendency. And these can be done at times in hospital as well. Next slide. So this is an EEG, and the top 4 rows are the left side of the brain, and you see what looks like a sharp wave, sharp and slow wave, or a spike in wave, and that's the hallmark of epilepsy. And this is the left temporal lobe. This person had focal epilepsy beginning from that left temporal region. Next slide. Okay, so now we know that you have epilepsy. We know the seizure type. So how do we treat? Well, medication and non-medication. We have lots of options. Medication is the mainstay of treatment with which most people with epilepsy are well managed. Surgery and implanted devices, we have new options, and diet. Next slide. Our anti-seizure medications are the way we treat, most commonly because they work. And truly, the overwhelming majority of people do very well without seizures or well controlled with our anti-seizure medications. So more new information. We used to call these anti-epileptic drugs. Now we call them anti-seizure medications because that's what they are. So years ago, we had 4 drugs: carbamazepine or Tegretol, Dilantin, Depakote, phenobarbital. Then after a number of years with no new drugs, all of a sudden we have over 20 new drugs and new formulations of our older drugs and new classes of drugs. So I am just going to go through and say these really quickly so that you've heard them and know how to say them if your doctor says, oh, let's try A, B, and C. So on the left is the generic name. On the right is the brand name. So felbamate or felbutol, used infrequently, gabapentin or Neurontin, and that is used for other things as well, more for pain. Lacosamide or Vimpat, lamotrigine or Lamictal, levetiracetam or Keppra, oxcarbazepine trileptal, pregabalin or Lyrica, rufinamide, Banzel, tiagabine, Gabatril, topiramate, Topamax, zonisamide, or Zonegran. Next slide. We had our newer, now we have our newest medications, the third generation. So this is in the last several years that these have been approved. And I will tell you, I am involved in a number of clinical trials and studies, and I've been involved in many of the clinical trials with that right-hand column and in trials with all four of these newest drugs that now have been approved. So eslicarbazepine, Aptium, brivaracetam, Briviact, perampanel, Fycompa, cenobamate, Xcopri. And the most recent drug approved was Xcopri or cenobamate, which Dr. Jackie French talked about in her wonderful keynote presentation. This actually was our first COVID launch drug approved a year ago, and she talked about seizure-free rates. I will tell you, when these newer drugs, when they're approved, they're not new. We have been using them for a number of years in our clinical trials. So there is quite a bit of experience, and all of these are FDA approved. And our patients also have access to some of these before they're released. And thank you if any of my patients who've been involved in these trials or former study patients are watching. Thank you for what you've done to allow us to get approval so everyone has access, because each one of these, all these newest drugs are game changers. So we also have another grouping, the bottom half of the slide, that are used. Also, many of these are relatively new or newer. And these are used or indicated primarily for the serious seizures in young children, the syndromes, Lennox-Gastaut syndrome, Dravet, and tuberous sclerosis. Those young children grow up and then we see them as adult neurologists. So we also use some. And I'll point out Epidiolex is used for the seizure types with those in adults and children, as are some of the others. But note that there is no THC, which is the psychoactive component of cannabis in these drugs, because that can increase seizures, so not psychoactive. So cannabidiol, Epidiolex, everolimus afinitor, stiripentol, fenfluramine, recently approved, and clobazam, Onfi, and just hot off the presses, Sympazan, a film to use for clobazam. Next slide. Okay, then we have a class, an exciting class of rescue medications with some new opportunities as well. Lorazepam or Ativan has been around. That's been our only option, oral or in the cheek or liquid, and diazepam and rectal diazepam or Diastat. And rectal diazepam has been our main option for seizures that continue or clusters. This is like a suppository, which sometimes is challenging for group homes, for workplaces, for adult people with epilepsy, for people who live by themselves. So we now have two great options, which are nasal sprays. Intranasal midazolam or nasolam, and intranasal diazepam or Valtoco. Great options. So these are meant for cluster seizures, when you have a seizure and you know that means you're going to have another one and another one, or prolonged seizures. Also, new information, the inhaled alprazolam, the oral inhaler, is currently in clinical trials. Next slide. Okay, so just very briefly, because this is not what you're looking at as newly diagnosed, but we have new options in brain surgery. Brain surgery is a wonderful option for people who have failed medications, and particularly if the seizures come from one spot in the brain and not where your speech and memory are. And so lobectomy, lesionectomy, and now we have laser surgery, which is less invasive. Next slide. There also are the implanted devices, also typically for people who have failed medications. The vagus nerve stimulator, and that is an implanted little pacemaker like computer that goes in the chest wall and wraps around the nerve in your neck. There's responsive RNS neurostimulation and DBS, deep brain stimulation, again, primarily for focal seizures who have failed medication. Next slide. Diet. I frequently get questions about diet. So ketogenic diet is a diet that we use in young children with the difficult epilepsies. It's a low carb, very high fat, quite complex diet to follow, and a dietitian needs to be involved. It's been very successful in some patients. Taking off from that is our modified Atkins diet, which is a high protein, low carb diet. And that has been shown in clinical trials to also decrease seizures. And both of these are used with medications. Next slide. Okay, and there are other strategies as well. We'll talk about, and Dr. Zaccarello will talk about as well, involving stress and behavioral management. So let's talk about then how to manage your seizures. How do we get to no seizures and no side effects? Next slide. Well, there are triggers. There are things that make it much more likely that you will have a seizure. You got the right diagnosis, the right dose, but having seizures. So the number one reason for seizures in people with epilepsy is missing medications. Non-compliance or non-adherence is what we call it in the literature. Lack of sleep. Sleep deprivation is number two. Fever or illness can be a trigger. Caffeine, high dose caffeine, even modest amounts at times. Energy drinks are a real problem, or can be. I do not recommend. And alcohol. Alcohol will increase the risk of seizures in several ways. When you're drinking, that increases the risk. But also when people drink large amounts and then stop abruptly, there may be alcohol withdrawal seizures. Alcohol also may affect the way you metabolize your drugs. Recreational drug use can cause seizures. We talked about smoke marijuana increasing the risk of seizures. Seizures may occur more often with the menstrual cycle or have a hormonal trigger. We actually have a name for that. We call it catamenial epilepsy. What about flashing lights, photosensitivity? That can be a trigger in a small number of people. We often can pick that up on the EEG when you have photic stimulation, when there are those flashing lights. So that you should talk about with your doctor. Sometimes we limit the amount of time people are on video games. I've had patients that has clearly been a trigger. And stress. Yes, stress can increase seizures. So I'm looking forward to hearing what Dr. Zaccarello has to say about that in managing the stress. Next slide. So, what are the strategies that we use to put all this information into play? Next slide. Well, first of all, take your pills. Non-adherence or missing pills is the #1 cause of seizures. Adequate sleep. Everyone needs different amounts, but make sure you get enough for what your usual need is. Healthy diet, minimize alcohol and caffeine, moderate exercise, and, oh yes, take your pills. Next slide. Why do we care about taking medications? Yes, it causes seizures. There was a wonderful study published, written by Dr. Ed Fote, who is a wonderful epileptologist and a friend that's cited frequently. And he demonstrated in very large numbers that non-adherence definitely produces increased injuries, hospitalizations, accidents, ER visits, increased costs with significant morbidity and illness and mortality or loss of life. Next page, slide. Okay, so how do people remember to take their pills? And I ask my patients, have you missed a pill? How many have you missed? Which dose? So here are the strategies that have been most successful. First of all, weekly pill boxes. Set them up once a week, and it's fine to have your caregiver, spouse, parent, or child, or whomever remind you or sort of keep an eye on it, or you may not need to. Setting an alarm on your watch or phone is often very helpful. There are phone apps that people find helpful. Take your pills and managing them. I have one patient who uses Alexa to remind her to take her medications. You should carry a few extra pills with you in your purse, in your pocket, at work, or in your car. So when you dash out of your house in the morning, or you're unexpectedly away for the night, or have one of those oh blank moments, you'll have the pills with you. You also should never pack your medications in your suitcase. One of the worst calls, one of my least favorite calls from one of my most conscientious patients who called after arriving in Mexico. They had taken his carry-on and had him send it to under the plane. And when he got there, his suitcase had not arrived with his medications. So don't pack them in your suitcase. Take them with you, even if it's a day or two with you. And for this day and age especially, fill your prescriptions ahead with the mail order pharmacies. There can be problems filling or in the mail arriving, or there may be a problem at the pharmacy where they don't have the pills in stock, or they haven't sent the prescription out, or other issues, or with the doctor's office if our electronic health records happens to be down, or the pharmacy didn't send it, or if the doctor is out of the office for a day or two. So fill your prescriptions ahead. Next slide. Then how about for your appointment? Well, I really like my patients to keep a calendar, and I think everyone does. Write down your seizures and side effects and life events. Did they always happen with your menstrual period? Were the seizures always on the weekends? Had you missed a dose then? I love seeing when patients come in and initially we have 3 or 4 a week or 3 or 4 a month. And then as we increase meds or add meds, then seeing all that white space. Bring your calendars to your appointments. If you have telehealth, even you can hold it up to the screen. You also should have a list of your medications with you. Bring it to your appointment, but also give a copy to your closest family member or whoever would go with you if you had to go to the hospital, or parent or child or whoever. And have a list of your questions and ask early. Next slide. What about side effects? Well, there may be dose related or drug related. And we don't want people to hate the drug rather than the dose. So what we do is often start low and go slow, low dose and increase slowly. This is for physicians and for you and our nurse practitioners. Take medications at bedtime if you're having side effects is often a good strategy. That means take your pills and get into bed. You should take medications with food. Some don't require it, but if you're having side effects, I would. And that means eat something and then take your pills. I often will try to make changes or increase medications on the weekend or Friday night, because if you need to adjust to the medication or if there's side effects, and side effects are not uncommon with some medications, then you have time to get used to it. And those side effects, dizziness or sleepiness, are often are maybe the most common, and those improve. And then the other strategy, we may decrease your dose or slow the titration, but we often will decrease the other medications, which will really make a difference. And if we talk about tapering, the older drugs, well, they weren't controlling your seizures before either. Next slide. If they're still there, be open to trying a new medication. Clinical trials or study drugs also is a wonderful option to have access to some of the newest drugs, but also there's no charge, and we add the study drug to the medication that you're taking, and don't change what you're on. And we can talk about this more in the Q&A as well. And there is, for most of our trials, a placebo arm and a study drug arm, but at the end of the period where we're observing, everyone gets the study drug or the new drug in what we call the open label. So that may be an option for you as well. Next slide. And finally, the Epilepsy Foundation of Minnesota is a great resource. It's free one-on-one support. They deal with employment issues, other questions. Advocacy is very important, and Heather Bessnan, our host, has headed advocacy, going to the legislature. We have day at the Capitol, and if there's time, she may be able to talk about it a little bit more as well. And finally, there are even social events virtually to meet others with epilepsy. Next slide. So in summary, newly diagnosed epilepsy with all our new options, new medications and older medications, new treatments, new procedures, having strategies, all this information really makes it possible to live well with or without seizures, and does make it exciting to treat our patients with epilepsy, and a pleasure. Thank you.
Thank you so much, Dr. Joanne Rogan. That was an excellent presentation, encompassing all of the ways in which diagnosis, treatment, and new treatments can be such a pivotal role for our patients with epilepsy. In the next part of our session today, we'll do the Q&A with myself, Dr. Joanne Rogan, and Dr. Zaccarello, but I'd like to introduce Dr. Zaccarello to our group. He serves as the consultant and assistant professor of psychology in the Division of Neurocognitive Disorder, Department of Psychiatry and Psychology at Mayo Clinic in Rochester, Minnesota. He is the Pediatric Neuropsychology Postdoctoral Fellowship Specialty Director. He's also the director of the Intraoperative Brain Mapping Program, providing liaison and clinical service in the Neurologic Surgery Department. He's the clinical director of the Adult Mood Disorders Program. In history, Dr. Zaccarello completed both a Master's of Arts degree and doctorate in philosophy in clinical psychology from Case Western Reserve University in Cleveland, Ohio. Additional training included a neuropsychology pre-doctoral internship at Rush University Medical Center in Chicago, Illinois. Dr. Zaccarello completed his pediatric neuropsychology postdoctoral fellowship at the Medical College of Wisconsin in Milwaukee, Wisconsin. He has been a co-investigator on several local, private, and federal grants. He has published on a variety of topics ranging from learning disabilities, pediatric epilepsy, the impact of early anesthetic exposure on neuropsychologic development, pediatric pain, spina bifida, child-adolescent depression, pediatric postural orthostatic tachycardia syndrome, or POTS, pediatric multiple sclerosis, and Niemann-Pick's disease. He has presented locally, nationally, and internationally on a variety of pediatric neuropsychological topics. Dr. Zaccarello has served in the United States Army Reserve for the last 20 plus years. He has served in a variety of positions at the company detachment, battalion, and brigade levels, and he is deployed to Iraq in support of Operation New Dawn. So we welcome Dr. Zaccarello.
Thank you for having me.
Yes, thank you. All right. Well, so one of the questions, I know there were a few things that we potentially might talk on, including maybe more information from Dr. Rogan on clinical trials, or Dr. Zaccarello, if you'd like to discuss a little more on the association with stress causing epilepsy. But one question that comes into the foundation quite a bit. And I think I will go to Dr. Rogan first on how would a patient decide, a patient or a parent, decide the type of doctor they should be seeing for epilepsy?
Thanks, Anna. So when someone has a new seizure, they'll go to the emergency room. They may see their primary care physician or primary care health provider with that first seizure, and they may do some preliminary testing. When it comes to actually starting treatments, there are some drugs that we use very commonly, and your primary care provider may start those as well. But I am a little biased, but I think seeing a neurologist or epileptologist or a epilepsy care provider is a good idea for a first seizure. Make sure that there are not other causes going on, and also look at specific treatments because there are so many wonderful choices. And if you are following, if you're well managed, your drugs have been stable, and you're seizure free for some time, following with your primary is good. But if you're having seizures, seeing someone who's familiar with all of our options is, I think, a good idea.
And I can speak to that a little bit. In my practice at the VA, I do quite a bit of diagnosis, and my colleague, I have a nurse practitioner colleague as well, and we were recently talking about how we really do think that patients should see the neurologist / epileptologist first, and that we can support more in terms of management and ongoing maintenance. So that's something we may be discussing going forward in our practice. So I guess I say that in support of your in support of your opinion.
Thanks.
I don't know if you would like to speak to that, Dr. Zaccarello, in your experience.
Thank you for the question. So just very quickly by context, as a neuropsychologist, most folks don't realize what I do or have seen one before. So I have specialty in kind of doing assessments. These are paper and pencil testing in individuals that have complex medical or neurological conditions such as epilepsy. And we try to capture a pattern of thinking skills, academics, and behavior and emotional functioning. To the direct question about what sort of medical provider one should see, first of all, I'm not a medical provider, so I just want to make that clear. But I echo what Ms. Shukla and Dr. Rogan has stated, that ideally you want to go to a specialist to make sure that you get the optimal care and the best identification of what seizure type you may have. Although well-intentioned, some other medical providers who don't have the expertise of a neurologist or an epileptologist might unintentionally mischaracterize or perhaps even misdiagnose a seizure disorder which is in fact actually epilepsy.
Yeah, and we see a lot of that in our population. In our EMU, we have patients from all over the country that come, and they've been on seizure medicine for 10 years. You know, they were told they had epilepsy, and we take a week with no medicine and find out it's very likely, a psychological distress syndrome, where they're, staring off or blanking out, and it's not an abnormality of the electrical activity in the brain.
So at least in pediatric populations, sometimes we see the converse, in that a child may be identified as misbehaving or having ADHD when in fact they have an underlying neurological condition that is in fact epilepsy. There's actually some compelling research out there that up to a year before a child has an overt seizure, they are having academic challenges or thinking skill challenges, suggesting there's something going on in the brain that's percolating before you have that first overt seizure event.
I agree. I have seen patients who come in with a first seizure, and these are adults, and or as potentially newly diagnosed. But then when we take a history and find out, have they had any other weird episodes, I always feel bad when I hear that they've been having what are probably focal unaware complex partial seizures for many years, where they suddenly may have a lapse or not be aware or have a stereotype deja vu, and they thought that everyone had them. And that actually is part of the seizure disorder. You start medications and they don't recur.
So then I think our next question kind of flows into that. If you have a pediatric population or even adults where they've had abnormal behaviors for some period of time, and then it's discovered that they in fact have seizures or epilepsy, is it dangerous to have seizures, and can they cause brain damage and death? Dr. Rogan, I think I'd go to you first.
So typically seizures don't cause brain damage. If seizures, the generalized tonic-clonic seizures, are very prolonged, then there is that risk, and that's why we have a rescue medications. But the seizures alone typically don't. Having said that, there are risks with having seizures, risks of injuries, risks of falls, of fractures with falls, of dislocations of bones. We've seen, I just found out that a seizure is the #1 cause of a posterior dislocation of the shoulder. So definitely there are risks. And the concern, even with our focal aware seizures, is that they can evolve into our focal unaware and generalized tonic-clonic seizures. So there are those risks with it. So that's a reason we want to control all the seizures.
In terms of, the kind of things that I evaluate or look at, again, cognition or thinking skills, academic functioning, and behavior and emotional functioning, what the data suggests is that the longer that a seizure goes uncontrolled, and I don't necessarily mean in terms of someone having a single prolonged seizure, but having epilepsy that we can't get under adequate control, the higher the risk of them developing thinking skill weaknesses or academic challenges. Not guarantee, but heightened risk. There's also very compelling research that when we look at quality of life in individuals with epilepsy, having adequate seizure control is a powerful predictor of whether or not someone is maintaining adequate mental health and stress levels.
Thank you so much. All right, Dr. Zaccarello, let's go to you for this question. What can parents do to help their child with epilepsy deal with the diagnosis to live the fullest life?
So Dr. Rogan kind of hinted earlier in her presentation about some general self-care issues such as adequate sleep, adequate hydration of the right type of liquids, adequate eating. And the same thing kind of follows through in pediatric populations. What we see over and over again in pediatric populations, and kids have differing levels of acceptance of this, is as a child having a seizure where you lose control or are not aware of what's going on can be a very scary phenomenon. And we have found that educating the parents on what epilepsy is, if they have a focal epilepsy in the brain, a specific spot in the brain where it's coming from, how that can affect learning, behavior, and emotions is a powerful tool that they in turn can also help their child understand what's going on. Because with understanding, it kind of heightens the level of anxiety and fear that children may have. The Epilepsy Foundation of Minnesota has Seizure Smart Schools, which I'm a huge proponent of, in which individuals from the Epilepsy Foundation will go into school systems at the request of parents to provide education to not only school personnel, but also other students. There's some data coming out of Canada, based on one of my colleagues, Dr. Elaine Wuerl, at least in high school populations, that although a minority, it's shocking how many high school students think things like epilepsy is contagious, or that people with epilepsy should not marry. So when you have that level of disinformation going on, I think it's really important to provide kind of accurate details to families that have someone with epilepsy so they can better inform others.
Wow, thank you so much for sharing that.
I agree. Dealing with what has been the stigma of epilepsy is really an issue that the Epilepsy Foundation has done a lot of work on, and great work. The Seizure Smart Schools, they're also the shining stars, the kids with epilepsy, but also raising awareness. And there are some wonderful spokespeople. Um, Coach Kill, when he was here, talking about his epilepsy, which unfortunately was not well controlled when he was here, with, guess what, missing medications. I didn't take care of him, so I can say that from the general press. But he is a wonderful champion for epilepsy, and other people talking about it as our role models, like our KSTP news reporter Ashley Zoka, getting up before several hundred people and emceeing, but also talking about her seizures and how well she does. So I agree, there's a lot of work to be done.
A lot. Yeah, that school I worked at that I mentioned at the beginning of the presentation had very veteran staff who had been working with that patient population for decades. And when I came on, it was very obvious that there was a lot of anxiety around seizures. So I, in fact, brought in the Seizure Smart School program to give them an unbiased presentation from the Epilepsy Foundation with just fact-based information so that they could hear it and digest it from other sources. And it was well received. So that was a really nice resource to have available in the community.
It's not been, if I may, just real quickly about Seizure Smart Schools. I will oftentimes make a recommendation to families. Again, this is more from a pediatric perspective, that if Seizure Smart Schools is allowed to come into the school system, actually have the child or adolescent be an active participant in the training. Most teenagers are quite resistant, and understandably so, from doing that. But the few occasions where I've had that happen, the reaction and the amount of support that that individual has had has been powerful, and very kind of life altering for them. So trying to, empowering the child or the adolescent with epilepsy, having the Epilepsy Foundation as a support network, it can also be a very powerful tool to use.
Awesome. Thank you so much for sharing. All right, we have a clinical question from our participants. And the first one is it common to become resistant to a drug after a period of time? So Dr. Rogan, I'll go to you. In your experience.
There are some people who have been on medications for a while and then they're no longer effective. There are other people who have been on the same medication, same dose for years, for decades, and do well. So most drugs don't have tolerance, but that can occur. Sometimes it's dosing, and there may be drug interactions with something that you are now taking that's lowering your level, or other medications that interact, or there may be other factors. So it's good to reassess And that's why even patients who are seizure-free, and excluding the reason you have to see someone once a year to give them medications, but checking in to see if there are spells. Are the medications still working? Are there other things that are going on in their lives?
I can share a story without divulging too much information, but in a patient of my own who was on dialysis and Dilantin. He had been on Dilantin for over 30 years, really did great, only had one seizure in his entire life, but a pretty dramatic one that so he didn't have epilepsy, but he was really resistant to going off medicine because of the trauma that he had with that one seizure. And when he started dialysis, vitamin D becomes an issue, and we're worried about osteoporosis, and it becomes kind of complicated. So we decided to try him on a different medicine. And all of a sudden, he's having all these issues. So we actually tried him out on his Keppra level before and after dialysis, and he had dialyzed most of the Keppra. So that was pretty frustrating. So I I share your sentiment that you really have to look at the entire picture of the patient. If they've done really well on one medicine for a long period of time, you balance the side effects, and Keppra is really great with few side effects and really does well with most other medicines, but in certain particular patients, it may not work. So yeah, looking at the whole picture in terms of is it really actually that you're resistant, or did you start a new medicine, or are you doing something else that might be lowering your seizure threshold?
Exactly. And then there are some things like you point out with some of our medications, we know they're renally excreted. We know after dialysis or whatever, you may have to give an extra dose, or we have to check levels. And in our pregnant women, and that's a whole nother talk, but during pregnancy, the levels of our anti-epileptic drugs go down because of a change in how they're metabolized. And so then we have to check levels and keep increasing. So it's not that they're not effective, it's not the right dose.
Absolutely. So the next question is whether or not seizures can be seasonal. And I guess first, Dr. Zaccarello, I'd ask you if you find that you're doing more of your work at a certain time of year. Do you notice any sort of seasonal things with the pediatric population, or no?
Yeah, I can't say that I notice dramatic changes in kind of presenting complaints or what thinking skills look like as a function of the seasons that I can attribute directly to their epilepsy.
Dr. Rogan, have you ever had that experience, or do you know any research that would suggest that seizures would be seasonal? Excuse me.
I agree with Dr. Zaccarello. I don't think seizures are. There are some conditions like migraines that occur more frequently in the spring and the fall. But with seasonal affective disorder, I'd welcome Dr. Zaccarello's comments that mood and depression clearly play a role as a comorbidity or something that exists with seizures, but not necessarily causing seizures.
Exactly, Dr. Rogan. And obviously, when you have an individual who's having seizures, it's critically important to get the seizures under control. And I don't want to negate that by any stretch of the imagination, but as patients, but also as family members, I ask that you also entertain, we've kind of mentioned this earlier, holistically, looking at the person with epilepsy. We know that there is a very high risk of mood issues, depression or anxiety in individuals with epilepsy. So it's important that everyone's kind of aware of that, to even include the provider. The medical provider, and ask the question about mood or changes in mood, and then refer that person to the appropriate mental health professional if need be for additional triaging, assessment, and even treatment.
Thank you so much. And speaking of comorbidities, Dr. Rogan, what would you say is the association between migraines and epilepsy, if anything?
Well, there is some increased risk of migraines, increased incidence. Some of our anti-epileptic drugs actually are effective and used both for migraines and epilepsy. So there also is some underlying EEG findings that have some similarities, more on a research basis on people with seizures and migraines. But they don't typically cause one another, but we see it more frequently in people with epilepsy as well.
Dr. Zaccarello, do you happen to notice because other diagnoses do come up, do you happen to notice that in your practice, that pediatric patients do have comorbid migraine and epilepsy?
I wouldn't say in a pediatric population, I see, I mean, certainly headaches, is it frequent? I can't say I would say that, but there is certainly, I come across patients in my evaluations that also experience headaches or migraines as well.
So I will say that sometimes people will have a headache after they've had a generalized tonic-clonic seizure or a seizure. And there are types of migraines that have neurologic symptoms with them. We call them complex migraines or complicated migraines. And there are those that occur only, the migraines with those symptoms, migraine equivalents or complex migraines. And sometimes it's hard to tell. We have to do an EEG or sometimes ambulatory EEG if these funny spells are a migraine warning or aura without headache, or are these our focal unaware seizures?
So it can be part of the diagnosis in terms of it's not necessarily a comorbid condition, but we're piecing out which one is which.
Correct.
All right, so I think the next question, Dr. Rogan, I'll start with you. Since you have so much experience with clinical trials, how do patients, could you tell us more about clinical trials if patients aren't being seen or they're being seen privately or elsewhere? How do they access clinical trials?
Well, thank you for that question. And I think now with COVID and all the vaccination trials and exciting news about them, it's people are becoming more aware, and that's wonderful. And also, I was really gratified at the prior session with Dr. Panovich and Dr. French when a survey showed that over half the people listening would have some interest. So to access to be in a clinical trial, you simply contact your neurologist or epileptologist and see if they are involved, but they're available on the web, or you can find out through the Epilepsy Foundation as well. So for us, for the clinical trials that I've been in, and many of them over the years, the way they're done is if you have the amount of seizures and the type of seizures to meet their inclusion and exclusion criteria. So typically it's maybe 3 or 4 focal seizures, focal unaware a month, or 1 or 2 primary generalized seizures, then you may qualify. And then there's the way it works is there's a period where we just monitor how frequent the seizures are to get a baseline, don't change a thing. And then one group gets a placebo or sugar pill, and then the other group gets the study drug, the drug we're looking at. And we don't know, they're double blind. So I don't know, the person doesn't know. And then we just count seizures, keeping all your drugs the same. And then at the end of that period, which is typically a 2 to 3 month period, then everyone gets that study drug. So you have a neurologic exam, you have some labs, probably an EKG. That's all covered by the study. So it's pretty simple. And then at the end of the open label, then often that continues for some time with many of the seizures till they're approved. So if you just talk to your epileptologist or neurologist, or their studies that we are doing. So it's pretty simple, and it makes such a difference for everyone with epilepsy actually having access to those drugs. And then no charge, and there is a small stipend that is paid for travel or whatever.
And how long are drugs typically in clinical trials?
That can be for many years. It can be several years. So the vaccination are incredibly short. Sometimes it's for a few years, 3 to 5 years. I just ended a study that has been going on over like 14, 15 years, which is the longest study I've ever been in. That was unusual. But usually all the studies from the very beginning, where they do phase 1 and work on it, phase 2 where it's a smaller group, phase 3 where many of them are, then they go for approval. So the study itself is usually about maybe a 6-month commitment, 4 months, 6 months. Each one is different. The first part is usually about 3 months, the important part.
Thank you. And Dr. Zaccarello, you mentioned, this is a little off topic, but you mentioned brain mapping. Could you speak to when brain mapping would be a part of your work, or what part of the process for a patient would they consider that?
So brain mapping is a procedure that we typically use for patients that have not responded very well to anti-epileptic drugs. It is also a procedure that we use on some patients where we've identified a focal or specific area of the brain that seems to be accounting for the epilepsy. That part of the brain may be near some areas that we call eloquent cortex. So areas that are very important for thinking skills. I think language is probably the most important area that we can kind of think of. And what happens in these brain mapping cases is that the patient at various points of the surgery is actually woken up. And what we do is we do some, I guess for lack of a better term, basic neuropsychological testing, where we use electrodes that stimulate the brain, kind of anesthetize the brain, I think for lack of a better term, and it mimics what would happen if that part of the brain was taken out. And we do some testing ongoing while this stimulation is happening to see when we're getting closer and closer to this eloquent cortex again. It's a way for this to help the surgeon guide how much tissue to be taking out so that's kind of a very simplistic way of describing it. It's for a very select number of patients. I oftentimes or almost exclusively defer to my neurology colleagues and my neurosurgery colleagues about when and if to use this sort of technique in the OR.
And how often would you say in a given year you might be participating in that?
So other centers have a fairly robust program. Here at Mayo Clinic, we're just standing our program up, to be honest with you, and then with the interference of COVID and restrictions on patient care, that's further hampered our patient census in this area. I think calendar year to date, we've done maybe 8 to 10 cases.
Okay.
The majority of those cases are adults. The youngest patient we've done is 15.
And in your experience then, when you say they've failed medicines, how many medicines have they been on by the time you're involved?
Well, I'd like to defer to Dr. Rogan about, to be specifically about when one trips the, trigger in terms of what is one, a medication failure, and two, how many medications one need to fail before they're considered truly refractory.
Dr. Rogan, what is your experience with medication failure? Like how do you describe that to patients? Like, we're going to move on because of X.
So in general, we try medication if there's still seizures or side effects after we get to the point where that dose or that level is typically effective. Then we will add another medication, take away the first medication, or if they thought there was some benefit, we may continue. We like having one kind if we can. And that can take a while. And if seizures are not that frequent, but still happening, then it might be a longer time to stretch that out. So there is a lot of discussion. People talk about having failed 2 anti-epileptic drugs and then going on to surgery. Because the numbers in some early studies suggested the chances are pretty low after that. Having said that, there have been other studies and reports that, including one by Jackie French and others, that even having failed up to 7 drugs or more might be yielding good results. So someone may then be seizure free. And I see people who have not been a surgical candidate and they've failed. Some in some of our studies have failed 10 drugs or 13 drugs. And now we find the right wrench, one of our drugs, and now they've been seizure free for 2 years or 5 years or driving. So the sort of short answer could be 2, but I think it's an adequate trial of medications, and that differs. If there's another drug that looks like it might work, it might work.
Thank you so much. Now, I think this will be our last question. If you could both speak to, we'll start with Dr. Zaccarello, and you kind of touched on this. How has the COVID-19 pandemic affected your ability to practice?
Well, certainly it's presented some unique, what I would call opportunities. Actually, here at Mayo Clinic, we have some fairly rigorous screening procedures when we have patients at least come into my specific practice. And believe it or not, it's kind of status quo. We are at this point still seeing the same volume or numbers of patients and still doing what I would typically do from day to day. So I've been very fortunate in that regard.
Absolutely. Dr. Rogan, how has it affected your practice?
So I agree. I think there have been opportunities and obviously a change. Telehealth has been a really excellent opportunity for many of our patients. I've continued to see patients and I'm seeing primarily telehealth for most of my patients and study patients in person with PPE. But for seeing people in group homes, in nursing homes, people who otherwise would drive in 3 hours or 8 hours or other parts of the country, it has been excellent. And I get to see people in their own homes and I see their pets. And if they didn't bring their list of meds, they say, wait a minute, let me go get my pill bottles. So it's changed, but we're managing. How about you, Dr. Shukla?
Yeah, I have in the epilepsy, I would say I do have half a clinic of general neurology where, Parkinson's and tremor are much harder to do via telehealth. But with epilepsy, it's been an absolute delight, especially when you consider that the patient is not typically the person that's able to tell you what happened. and our family members are our greatest allies. And it's been absolutely wonderful. You know, I had this patient, I don't know why he's at the top of my mind today, but he, the patient with dialysis, I would have had no idea that he was having issues without the fact that telemedicine brought his wife into the picture. And all of a sudden, we're finding out that he's in fact having problems. Otherwise, he comes to every visit a pure delight, telling me there's no problems and he's not having any intolerances. So I have found in my work that telemedicine has been absolutely wonderful, and most of my patients love it. Some still prefer face-to-face, and we are accommodating that even today, with PPE, of course. But in terms of if it's available, I would say patients have loved it, and it's been a good opportunity to take advantage of. So I think we have to close the question and answer part of our session, and Heather is going to kind of wrap up for us. And thank you so much to Dr. Rogan and Dr. Zaccarello for your presentation and participation, not only in lecture, but also in discussion. Thank you both so much.
What a wonderful discussion and such an informative presentation from Dr. Rogan. Thank you to all three of you for joining us to talk today about living with epilepsy and seizures. I know that we weren't able to get to everybody's questions. Thank you for submitting them. If we did not answer your particular question, or even if you just think of one later, please email us at admin@efmn.org, and we will work on answering the questions for you. Dr. Zaccarello mentioned his support of the Seizure Smart Schools program, and Anna actually also shared her own experience with the program. If you would like an EFMN staff person to provide training at your child's school, please visit the support and training page at efmn.org. In 2019 and 2020, our staff and volunteer advocates have worked towards advancing Seizure Smart Schools legislation in Minnesota. If you'd like to join our efforts during the 2021 legislative session, which is right around the corner, you can sign up for our advocacy campaign on the website's advocacy page to receive email updates on how to get involved. Lastly, I would like to remind everyone that we have open exhibitor meetings on Fridays starting at 1 p.m. If you are interested in speaking one-on-one with organizations and companies that specialize in epilepsy care, treatment, and devices, please schedule an appointment at efmn.org or email admin@efmn.org for assistance. Thank you so much for your time and have a wonderful evening.